what is the beauty about ankles? You always have the correct side with you. You have to check the other side. Why? Many, especially female football players, have laxity. Now, laxity has nothing to do with instability, but it might feel like if you have a laxity in an ankle with a patient who had a sprain, you might think it's instability, where it has nothing to do with it. How can you identify laxity in a patient?
Here's some tests. You flex the thumb.
Exactly.
flex
You
the-
have a few
the
possibilities.
extension.
You can ask to put the thumb on the lower arm. Now, laxity patients can almost push it there. Another one, elbow. You can have the hyper extension in the elbow. Many ladies have it. For example, the knee recurvatum. Ladies can have, not only ladies, but many times, the recurvatum of the knee. If you stretch your knee fully and you have that recurvatum, you have your thumb, your elbow, and your knee recurvatum, and you have an anterior drawer that is positive, don't think immediately about instability. Think about changing to the other side and seeing maybe there's a similar clinical test. So, all things to consider. Another thing, for example, the alignment is so crucial. We didn't really talk about it yet, but a patient with, for example, valgus knees, they will say, "Oh, doc, I have flat feet." It's always like that. They don't have flat feet, but because they walk like this, they walk internally. So you have to look at the ankle in combination with the chain of movement of the lower leg. Another thing is you have players who have flat feet. You have players who have cavovarus. Now we know that when you just look at the alignment, cavovarus people who have an injury, what do they mostly have? A patient with a cavovarus foot that twists in a normal ankle sprain. What is the first thing you think about? Metatarsal 5. A cavovarus foot that goes in inversion has hyperpressure on the base of the metatarsal 5. So never forget that the ankle is in combination with the knee and with the lateral forefoot. I really stress that because in many cases with our residents in emergency trauma, they, for example, will not ask for an X-ray of the foot, where they ask for an X-ray of the ankle, and you see later stage base metatarsal 5 fractures. Now, of course, we're all in a learning process, but the idea would be if you look at the patient just by looking and you see a cavovarus alignment with an inversion twist, ask for an X-ray of the foot, because in many times you will see something happening there. All things to consider, okay? So the anterior drawer test we just did. The second one is the Taylor tilt test. We go again. The Taylor tilt test, again, you have to compare with the other side, but it's basically putting the foot in neutral position, stabilizing the ankle, and going in full inversion. That's the Taylor tilt test. Now, somebody with instability will have a clicking or will go much further than the other side. You can compare it with a dial test in the knee, where you put the patient on the belly and you go outside and you will see the difference. So when you go both sides, you stabilize in neutral position and you go in Taylor tilt, or you can do like this. You can stabilize if the patient has too much pain by moving it. You stabilize the ankle and you really go in inversion. You will see a difference there. So with that, you can already identify mechanical instability. When we talk about the lateral ligaments from the ankle sprain, you also have the high ankle sprain, which is the syndesmosis. The syndesmosis has a whole different mechanism of injury and has also very different testing because of that. What are the tests that you use for syndesmosis? You have the squeeze test, you have the cotton test, you have the external rotation test, you have the fibular translation test, you have the crossed leg test, and then you have two things you have to always think about when you think about syndesmosis. It's the combination of squeeze test, medial pain, and radiation output. If you have that triangle, your light has to go up and say this might be a bad injury. Now, what do I mean by that? When you talk about syndesmosis, and the prospective clinical trials have shown that there's 3 reasons to worry about syndesmosis. It's when you have a positive squeeze test, where you put the foot in neutral position, you go just above the malleolus and you squeeze the fibula towards the tibia like this, and you do it going up. If the patient has apprehension here, you have to watch out with syndesmosis. Don't push on the distal fibula because they will always have pain, but you go just above and then you push. The second reason is medial pain. It makes no sense in an inversion sprain grade 2 that you would have medial pain except if you have previous chronic cartilage damage there. So if you have medial pain, you have to check the squeeze test and you have to check the proximal fibula for the simple reason that it's a mechanism of external rotation, supination, or pronation. Does that make sense? So, medial pain, squeeze test, and then irradiation up. If you have pain from here upwards over more than 5 centimeters, you have an unstable syndesmosis. Okay? Other tests for the syndesmosis are the external rotation test, where you really stabilize the ankle and you go in external rotation. Now the Kleiger's test would be then you push against my hand and you have even more apprehension. The Cotton test is a medial subtalar glide test where you go medial and lateral, and in a syndesmosis that would be very unstable, you would really see a difference in translation compared to the other side. Kleiger and Cotton. And then you also have the fibular translation test where you take the distal fibula, and of course it's always a bit painful, but you kind of do this movement, okay? So where you try to get the fibula posteriorly. Now our biomechanical data has shown that everybody thinks the syndesmosis opens like this in instability, but it's not enough. We see that it opens like this and goes posterior. So if you have an instability, your fibular translation test might show you clicking towards posterior. So always think about it. Now, all these tests show that there's not one test that is the best one. If there would be one test, we would use that one. So you have to remember that these are tests that you can use, but none of them is pathognomonic. So it's something in your history taking, in your listening, in your looking, that helps in your testing, but it's nothing clearly defined. So hopefully one day we will come up with a test that we say this is the one to be sure. The squeeze test is the one that is mentioned as the best one, but we are currently performing a study that is showing that it's not true. It's not as specific or sensitive as we think. So we're not there yet. Another test is the cross-legged test, where I will ask you to put your knee like this. You leave the ankle floating and you push on the knee. If you push on the knee and there's pain there, this is also a sign of syndesmotic injury. So we talked about instability, about syndesmosis. Any comments on that? What's the number one thing that you have to ask when you think about a cartilage lesion in the ankle to the patient? Sorry? Locking, yeah? You have locking and swelling. Now locking is of course an end-stage cartilage lesion. What would be a stable lesion? What would be the thing you have to ask the patient? Now I will tell you. You have to ask.
Drop or landing?
Sorry?
Landing or drop?
Yeah, it can be the mechanism. If you have a big inversion sprain and you have pain here, it might be the complication of the sprain. But what the patient will tell you is that all the pain here, for example, the swelling, the discomfort will be superficial. But somebody with a cartilage lesion will tell you, I have deep pain. The pain is deep inside. Deep inside towards the posterior side. Now that's not typical for any ligament injury. So deep pain is what you ask, because that will guide you towards intra-articular pathology. Syndesmosis, instability, cartilage, and then we come to the impingement test. There's anterior impingement and posterior impingement. Impingement means that there's a conflict, whether it's soft tissues, synovitis, calcifications, free bodies, osteochondromatosis, osteogonums. Anything can be there to tickle the joint and give impingement there. Now in football players it's going to be predominantly medial because that's where they kick. And it's going to be predominantly medial on the backside because that's where they hyperplantar flex. So, how do you identify anterior impingement? You put the foot in neutral position. You have the tibialis anterior tendon here. You go just medial in the soft spot. You feel that here. Do you see where my point is? So you put the foot in neutral position, identify the tibialis anterior, and then go to the soft spot. Yes, we have a winner. So if you have pain here, you have synovitis. Now you don't know what it is, whether it's a spur, whether it's a calcification, whether it's soft tissue, whether it's just irritation. But you know that you have an impingement syndrome. Now, pain exactly here could tell you in a patient with pain to say we have to look further for that. Same thing on the lateral side. You put the foot in neutral position. Yes. No, that's for the lateral. So anterolateral, as I said in a previous talk, you have spurs here that are mainly osteophytes in the joint. The lateral ones are basically antisophytes at the capsule. So here you identify more bony problems. Here you identify more capsular problems. But both sides are the soft spot to identify anteromedial impingement, most commonly, and anterolateral impingement, less frequent. Okay, that's the anterior impingement, 2 areas of pain. Then you come to the posterior impingement. Again, what is posterior impingement? It means patients or players who kick all the time. They prepare the shooting with their foot in hyperplantar flexion to shoot further. Now, on repetitive moments, if you have an ostrich going there, that can become unstable, can become painful, can affect the flexor hallucis longus in the area. So that synovitis, that can create posterior impingement syndrome. Also here, it can be soft tissue or bony, or something else, but less common. So what's the test for posterior impingement? There's 2 tests. The first one is to create the conflict, recreate the conflict. Okay? How do you do that? By just neutralizing the foot and going in plantar flexion. Now, somebody who has posterior impingement acutely will jump up the roof if you do that, okay? Just by doing so. Of course, if you have an inversion sprain patient with pain and swelling there, they will also say it's pain, but not there. They will not identify the posterior part of your ankle. They will say the pain is here. So you just try to go neutral and go in plantar flexion. Okay? That's the first one. What's the second one? It's the flexor hallucis longus test. If you go in plantar flexion and you ask the patient to move the big toe and you press on the posteromedial area, that will be also a trigger for pain. Okay? So again, you have the hyperplantar flexion test and you have the FHL test, where you put your finger on the FHL pores, backside, and you move the big toe in slight plantar flexion. That is also an apprehension test for posterior impingement. What's the other thing? We have the fractures, but we discussed the Ottawa rules already. I think that's basically what I wanted to show in a clinical perspective. Anybody wants to add something? Putting the foot in neutral position, you have your distal fibula here, and you go into the soft spot, distally and medially. You have here, and if you then do an eversion, inversion of the subtalar joint, you have an appreciation of that area where there can be synovitis. Now, it's my experience that if you have an ATFL injury and you do a sinus tarsi test, it's always positive. So it's a complex of swelling and pain where the first hours you have absolutely no idea what's going on. You have pain on the ATFL, you have pain on the CFL, you have pain over the sinus tarsi, and you can have flexor retinaculum pain all over here. You can have syndesmosis combined. In 20% of inversion sprains we see combined syndesmotic pathology. So it's a whole complex that is not showing you the truth in the beginning. But that's where our algorithm that we just discussed can help us in guiding ourselves a little bit towards a solution.